So before we get started, I just wanted to go over a few housekeeping items and let you know how you can participate in today's webinar. So a lot of you will have worked with GoToWebinar before, but just to give you a little bit of a review. Here we're looking at an example of the GoToWebinar attendee interface, which is made up of two parts. So we have the viewer window, which is what is shown here on the right, but it might be on the left on your screen. And that depends on your browser or computer operating system. And that allows you to see everything the presenter will share on their screen. The control panel, which is shown here on the left, but it might be on the right on your screen, allows you to participate in the webinar. So by clicking the orange arrow button, you can hide or show your control panel. You can also set the control panel to auto-hide or not to auto-hide by going to the View menu. We want to note that all attendees are in listen-only mode, and you're going to be muted during both Kersten's, mine, and Tuyen's presentations. To participate, you can click the blue Raise Hand button shown here on your control panel. And alternatively, you may also submit questions in writing during the presentation by typing them in the questions field. We're going to review questions as they come in, and we'll address them during the Q&A session, which are going to be held after the presentations. So as I mentioned, today's webinar is going to be recorded, and you're going to receive an email with the link to view the recording of today's presentation, as well as handouts, which I think are really key after the webinar. So we're excited to present you with today's webinar on how payment reform efforts impact you and your health center and what steps you can take to ensure that funding remains intact. What we're going to be covering today is to understand more of this national and state payment reform landscape, including current administrative changes. We're going to learn about different payment models that are being approached in different states and why. We're going to learn about how some health centers are documenting the social determinants of health and how this can inform delivery system reform. And we're going to find out different strategies and tools to connect with key players on the state level. So you're going to get a survey after this webinar, and we highly encourage you to fill that out. Any feedback is really helpful to us in being able to provide training that fits your needs. So with that, I'm just going to give you an overview on who's speaking today. Right now you're hearing from me, Isha. And our speakers are Kersten Lausch, who's the Deputy Director of State Affairs at NAC, the National Association of Community Health Centers. And followed by Kersten, Tuyen, my colleague from AAPCHO, who's the Director of Training and Technical Assistance, will be giving you an overview of prepare and how to document social determinants of health. So with that, I leave it to Kersten.
Thank you so much, Isha, for having me today. It's always a pleasure to partner with you all. So I'm very excited about this conversation. I think, before we get started and talking about a lot of the activity that are happening at the state level and some of the trends that we're seeing, I wanted to take a step back and talk a little bit about why are we engaging in payment reform. So let's go ahead and we'll head over to the first slide here. So why are we talking about reforming payment? What is this all about? So what we're really trying to achieve as a healthcare system is how do we really improve the patient experience, improve our quality, and reduce the system costs within our the healthcare system overall. We pay a lot in the United States for healthcare, and we don't really have the best outcomes. And so the talk about payment reform is really about getting at better quality and a more cost-effective system that's better for the patient as well as the providers. And so a lot of times this goal, this overarching goal, is called the quadruple aim. And so you can see here that there's really 4 components of this. And ultimately, payment reform, or reforming the way that we pay providers, is meant to be a facilitator or a tool to get at the delivery system transformations that will allow providers and patients to get the outcomes that they're looking for, as well as payers. So before we kind of move forward about, where is the healthcare system going and where are health centers at in all of this, I think it's important to always kind of start where are we at? What are some of the basics and what are the systems that are in place, and what are some of the opportunities within those current systems? So just a nice little refresher. I know a number of health centers are very familiar with their payment methodology, but it's a good reminder to kind of go back to basics. And so kind of keep with me as we kind of discuss a little bit about this. I know you'll probably be very familiar. But first, let's kind of talk about Medicare. So in Medicare, health centers receive what is called the prospective payment system for Medicare, and it was created by the Affordable Care Act. And it's a single bundled national rate that's adjusted for geography. And health centers are paid based on the PBS rate or their G code, whichever is less. And so it's important to be thinking about how are you coding these services and all that you do, because health centers do a lot during a single service. And so being able to document that is an important key piece of the Medicare PBS rate. And so this payment methodology within Medicare is paid on a face-to-face visit with different kind of specific provider types. And so you can see those different providers listed on the screen. And so I'm sure a lot of folks are familiar with this model. And then we talk about kind of the basics within Medicaid, as Medicaid is the largest payer revenue source for health centers. It's important to kind of refresh and think about really what is the payment methodology within Medicaid for health centers. So rather than being paid fee-for-service, health centers receive a single bundled rate for each qualifying visit, very similar to the Medicare PBS. And this single rate pays for all covered services and supplies provided during the visit. Now, in 2001, Congress created this unique bundled payment for health centers for a couple different reasons. First, the payment methodology ensures that there's predictability and stability for health centers. As we all know, health centers, by both their mission as well as by regulatory requirements, must serve every patient who walks through their doors, no matter their insurance status or their ability to pay. And that's a very key point of the health center model. With the exception of emergency rooms, no other provider has that type of requirement. And so it's important to keep that stability within the health center model. And second, the payment methodology also ensures health centers are not forced to divert their federal Section 330 grant funds to subsidize low Medicaid payments, as federal grants are to support operations and care for the uninsured. So that's another key component in understanding of why health centers have this payment methodology. So under the law, Congress provides states with really two options. A state can implement the prospective payment system, the PBS, as described in law, or a state could implement an alternative payment methodology, or APM, for health centers. So they can implement that APM as long as two things occur. First, the total reimbursement under the model is at least equal to the PBS rate. And then second, each participating FQHC agrees to that payment methodology. And so it's important to be really engaged in a lot of the conversations about implementation of your PPS and what that looks like. Because some states have implemented the PPS methodology, but how they've implemented it really varies. And that varies state by state, including what services are included in the PPS rate, which providers are eligible to generate a billable visit under the PPS rate beyond the 5 federally required providers, and how the payment really is processed. What does that system look like? So there's 23 states that have gone the other route and implemented an alternative payment methodology. So in some states, that payment methodology looks very similar to PPS, but may have some technical differences, like which inflation rate it uses. So, just some important things to understand. But we are seeing a new wave of FQHC APMs that health centers are developing with their state in partnership with their state primary care association, which we'll talk a little bit more about later. But I do want to touch on one key policy item here. So within Medicaid, states have the ability to really shape a lot of what their Medicaid program looks like. And that means benefits, how eligibility for enrollment in Medicaid, how providers are paid, all those different pieces. But with health centers, there's, you have that federally required statute saying how it's either a PPS methodology or an APM methodology for health centers. But as with a lot of flexibility within the current statutes, states are allowed to waive certain provisions to shape their Medicaid program in different ways. And it's a process called an 1115 waiver. And that's an application that goes to CMS, and they can ask to waive certain provisions. And so Medicaid's or FQHC services, as well as payment, so both PPS and APM, are eligible to be waived under a 1115 waiver. CMS has not historically approved such a waiver for a statewide, but I think we don't see one in place. But I think it's important to understand that with the current administration, there's a lot of openness to giving states increased flexibility. And so it's really important to stay plugged into your state primary care association, who's doing a lot of that work, monitoring activities within the state, to be aware of what this, any activities, and if your state's seeking a waiver, and then what that waiver includes. Is it impacting patient benefits, eligibility, or could it be impacting FQHC services or payment? So just a little note on that. So now we've touched on the basics, and let's get into talking a little bit about the payment reform pieces. So we like to use this format to describe a little bit about what payment reform looks like for health centers. So you see at the bottom is the base payment. So that's your FQHC, PPS, or APM. And there's flexibility within the model because it allows, since it is a bundled rate, of being able to deliver a lot of times the right services during the right time for a patient. And so that you have that base payment in place. And then layered on top, a lot of times we see within states what we refer to as investment payments. So these are payments that provide for infrastructure and ongoing services needed for the implementation of maybe a patient-centered medical home or delivery system transformation, and maybe subsequent accountability outcomes. A lot of times you see this as maybe a per member per month payment, and we'll talk a little bit more about those later on and where we're seeing those in the states. And then layered on top of that is talking about those payments for performance, those incentive payments. So these provide financial incentives for improving patient experience and population health while reducing those system costs. So not all health centers are currently prepared to really engage in all payment reform activities, whether that's investment payments or incentive payments. And it's important to really think about how do you prepare for that engagement. And so we have found through our research and a lot of best practice gathering that there's 4 key pieces, kind of steps that health centers can take to really effectively engage in this conversation, and how can they effectively move forward. So the first that we see is really developing and maintaining a robust understanding of payment reform, and both efforts, not only at the federal level, but really at the state and local level. The key partner here is your state primary care association. They're going to be the ones that are going to be able to keep you updated on what's really going on. And then it's an opportunity to really put forward ideas and engage in a way that we can move forward stronger as a health center network. And second is to really ensure that there's a clear shared vision for the organization towards achieving that quadruple aim. And that can be used to really assess any involvement in a payment reform initiative. Kind of what is that North Star goal that's guiding your organization through these initiatives, ensuring that you're still maintaining that mission and moving forward together as a system. And then third is assessing your really your current operations and capabilities, and where are some areas that maybe you need to strengthen your readiness in some areas. Are you documenting the value of enabling services you provide? Are you using data to design and monitor and evaluate payment methodologies? Some of those core concepts that a health center kind of needs to have under their belt to continue to move forward in payment reform. And so NAC has put together a payment reform readiness assessment tool so that health centers are able to kind of self-assess, and would just encourage folks to check that out. I'm happy to share that. And then lastly, really working to get collaboratively with fellow health centers, stakeholders, and partners to accelerate the transformation of health center and the healthcare delivery system. Really kind of the safety net is really stronger together, and when we're able to share our best practices and really move forward strategically as a network, it's a lot more effective and we're much more successful. And so again, connecting with your fellow health centers, your state primary care association, and other local partners, hospitals, other safety net providers is really key. So those are kind of the big fundamentals, but I just want to touch briefly on some of the things that we're seeing in both the federal and state landscape. So first we'll touch on the federal. I think the key piece within the federal government to be watching within payment reform is CMS. CMS has, tested different payment methodologies for a very long time. But what we saw with the passage of the Affordable Care Act was really more structure within the payment reform opportunities. The law created the Center for Medicare and Medicaid Innovation, which has a lot of more kind of a broad authority to really test different models. And so they're looking at what models improve quality without kind of increasing spending, or are they're models that are decreasing spending without reducing quality. And so we see a number of initiatives, kind of accountable care organizations, episode-based payments, different primary care models, both in Medicare as well as in the Medicaid space in partnership with states, and then different best practices and other outlets. And so within the federal landscape, kind of continuing to move forward payment reform, we saw the passage of MACRA. Now, MACRA, if I'm sure folks may remember from 2015, Congress passed the Medicare Access and Chip Reauthorization Act. So that's what MACRA stands for. And it created a new system for really sustainability for the formula for physicians or providers that are paid on the Medicare fee schedule. And the law really kind of combined several different quality-focused initiatives into one program, and that's called the Quality Payment Program, or the QPP. And under MACRA, Medicare providers can choose one of two tracks of how to engaging through alternative payment models, or advanced alternative payment models, or MIPS, a merit-based incentive program. So this went live in January of 2017, but as we remember, health centers are paid via a Medicare PPS and not on the Medicare fee schedule. So how MACRA impacts health centers is a little bit different. It's not, it makes no changes to your Medicare PPS rate, but it does provide an opportunity to engage in some voluntary quality reporting. And we actually have some other information about how MACRA impacts health centers that Isha will be sharing following the webinar. And so now, we have a broad idea of some of the things happening at the federal stage, but let's talk about the state stage. So we talked about, there's some different ways that states are approaching payment reform. And so there's first kind of the big whole system redesign approach. As we talked about, states can change how their Medicaid system looks beyond just kind of the already kind of system flexibility that they have, but modify some of those different pieces using 1115 waivers to really design the system. And so there are 33 states that have waivers that are focused on payment and 16 that are focused on payment and delivery, but 33 1115 waivers overall. And these 1115 waivers have been used to take a number of different approaches. States have designed provider-based kind of regional networks. So Alabama, for example, has regional care organizations that they're working towards implementing. And Oregon has coordinated care organizations. So these look a lot like accountable care organizations and provide opportunities for providers to really better collaborate and receive some opportunities for incentive payments, some of those different pieces, as well as investment payments. And then there's also states that have taken an accountable care organization approach, so that ACO approach. We're seeing Massachusetts just had a waiver approved by the CMS where they'll be implementing ACOs. A number of health centers are participating in that. Minnesota has had Medicaid ACOs for several years, and health centers have had a great experience within those. And then Vermont has had Medicaid ACOs, but is actually moving to what is kind of like a statewide ACO, which all providers will be included in, including FQHCs. So really a big move there to designing the whole system. And then another trend that we're seeing kind of related to this whole system redesign piece is managed care. A number of states have had managed care for decades or several years. And over the recent years, we've been seeing the number of states who have managed care or have moved to a managed care system have increased, as well as states who have maybe already have managed care in the state are increasing kind of the patient populations that are included within managed care. So we're seeing the enrollment of managed care increase. And so I think this is an important note, just because MCOs, those managed care organizations, are playing a bigger and bigger role within the kind of healthcare delivery system at the state level. And so thinking about what your relationship is with MCOs and what that looks like. And then next, of course, we're also seeing a lot of medical home or patient-centered medical home, health home, a lot of terms here, but really that medical home approach within Medicaid. So we're seeing first, I think there's a lot of different programs of kind of those traditional patient-centered medical home programs. Those might be directly with your state or with an MCO. And we see a lot of times payments really within these models vary. Those investment payments are very common, and we're also seeing an increase with incentive payments within these different models. Two that have kind of a more formal recognition. First is the Section 200703 health homes. This program is really targeted at patients who have chronic conditions. So specifically, those have 2 or more chronic conditions. Maybe have a chronic condition or are at risk for a second one, or have a serious and persistent mental health condition along with a chronic condition. So states have the opportunity to use kind of their already existing models within Medicaid to implement a health home program. And 20 states have taken it, and DC have taken advantage of this. And Section 2703 refers to the Affordable Care Act and the section within that, which in health homes was created. So we have an issue brief about this if folks are interested in more information about the model and which of those states are participating. And then last is multi-payer programs. We're seeing CMS has been doing a lot of this where within a multi-payer program really brings together different payers who align a lot of the metrics and systems to really get at some of that more system change. And so these payers are also a lot of times aligning their payment models and incentives. And so there's a couple of examples here. So there's the multi-payer advanced primary care practice demonstration. So this started out through CMMI, the Center for Medicaid and Medicare Innovation. And they started out with 8 states, but 5 states have had some real success here and have continued on past the demonstration. So you can see those 5 states listed here. And within here, we're seeing within this model, providers are, they must meet certain PCMH recognitions to receive these supplemental payments. And then there's also some opportunities for some incentive and investment payments through these. And then also the Comprehensive Care Plus model. So this is actually a CMS initiative that's targeted at physicians that are paid on the Medicare fee schedule. As we know, that doesn't include health centers, but states are taking it and adapting it in different ways so that health centers can participate in certain aspects. And so we know Ohio is one of those states. And lastly, just a piece to hit on here, coming back to really that FQHC specific payment reform piece. So I mentioned that we're seeing a new wave of FQHC APMs, where the health centers are working with their states to develop these models through their state primary care association. And these models are intended to allow for a more transformative use of the medical home and really start to address some of those provider burnout issues that we sometimes see. In these kind of models that are emerging, they de-link the payment from the face-to-face visit that we see under PPS and traditional APMs and converts that payment to a capitated rate. So a lot of times a per member per month rate. And so that's increasing the flexibility that a health center may have had than under the previous system. So instead of seeing maybe a billable provider, the health center is able to invest in other avenues that might better fit some of the needs that a patient has. So maybe being able to bring on a nutritionist on staff and really sustain that longer term, that might better fit a patient's needs on a certain visit, or being able to use all kind of visits that may not have been counted under the previous model, but could be better utilized under this system. So something for folks to be thinking about. Oregon has such a model in place, and California and Washington and Colorado are all working towards development and implementation of similar models. And I know there's interest in other states. So again, kind of cluing in if this is something that you'd be interested in, connecting with your state primary care association and talking about, hey, what can we do? How can we innovate? And I think that's the trend we see overall is where there's a lot of success is where health centers kind of bring the idea to the state first. We saw health centers bring the idea of health homes to their state and work together with their state to put forward that application. So I think we're seeing that in all assortment of payment models. So yeah, I think seize the day and take advantage of the opportunities out there and really leverage the resources that you have in your state. So I'm going to turn it back over to Isha. So thank you all so much, and interested in what folks have about questions later on.
Perfect. Thank you so much, Kersten. I just wanted to apologize to you all that the slides keep shifting. I'm not sure why that keeps happening, but we will get back to where we need to be eventually. So apologies for that flicking back and forth. Kirsten's presentation is a good segue into what we developed on behalf of AAPCHO. We've developed a set of APM principles, seeing that APMs really were a place, as Kersten had mentioned, for innovation, and knowing that AAPCHO member centers serve a very unique set of populations in the Asian American, Native Hawaiian, and Pacific Islander populations. So last year, we came up with a set of guidelines to address what member centers might want to see in an APM, to give them some guidance when approaching their states and PCAs. So as I mentioned, it was developed last year, and these principles work to ensure that the health center model of care is protected, that AAPCHO member centers are adequately reimbursed for the linguistically and culturally appropriate care that they provide, and the principles are trying to make sure that there's room for innovations and shared savings. As even within the set of member centers that AAPCHO has, there are stark differences from one member center to another. So our APM principles are as follows. They are to protect the FQHC model of comprehensive primary care. They are to innovate within the FQHC model. They are to ensure that effective bundle of culturally and linguistically appropriate services are reimbursed for. They are making sure that the patient is included in the development of the model, that health centers ensure that the different types of patients that they serve are accounted for. The principles also work to make sure that there is adequate pay for enabling services, which Tuyen is going to go into with her presentation. And we see a lot of those enabling services being provided by AAPCHO member centers, particularly as so many speak different languages and need various types of extra support. And the principles also work to prioritize data collection, as that is very key to our member centers, to make sure that not only the standard data collection is prioritized, but that we prioritize disaggregated race and ethnicity data. So with that, I'm going to pass it over to Tuyen, who is going to be talking about AAPCHO's Prepare project. Tuyen?
Thank you, Isha. Thank you so much for having me on the call. I want to apologize in advance that I have, I'm getting over a cold, so my voice might be coming in and out for throughout the duration of the presentation. So I'm going to be talking about our efforts with NAC, Oregon Primary Care Association, and the Institute for Alternative Futures on collecting and addressing the social determinants of health through the Prepare, what is known as the Prepare data collection set. So next slide, please, Isha, unless I have that option on my end.
I'll do it for you. Thanks.
Okay, thank you. So I'm going to be talking mainly about the importance of addressing the social determinants of health for improving patient and population health, and talk a little bit, just briefly, about the Prepare protocol, since we have so many resources available online for everyone, and it takes a little bit more than 15 minutes to talk about it, but we'll make sure resources are sent after the webinar. Next slide, please. So when we had approached the designing of the Prepare tool, we thought to accelerate systemic change. And really, when Kersten was talking about transforming delivery care system, and Isha was talking about the importance of data, we thought that by starting with collecting individual patient level data, we would have the tools and the information for us as the health center to make changes and to share what is so special about our patient population, what are some of the issues they're going through, so that at the state level, we could bring that data, that information about what the needs and what the barriers of our patients are, to have a better conversation about what does it mean to improve care for this population, what does it cost to the health center to provide care and improve health outcomes for this population. So really, in designing the tool, we had the systemic change in mind. Next slide, please. So why is it important to focus on the social determinants of health barriers or risks for our patients? And that's because research has shown that individual social determinants of health barriers affect and drive the patient health outcome even before they enter the health center door. So if we're really looking to make an impact on patients' ultimate health outcome, what we can't do within the health center is only address the clinical symptoms that they are presenting us with inside the patient-provider room. We need to have a better understanding of what are those barriers that are already affecting their health-seeking behavior, their responses to the interventions that we're prescribing them at the health center. So really have a better understanding, what are the things that are already affecting them before they walk in through the door. So next slide, please. And really having this information on what those needs and barriers are from our patients will allow us to better address them within the health center so that we really could improve outcomes and drive change. And really the main reasons are to provide better care so we know what their needs are, reduce costs, because ultimately if we can improve health outcomes, then we can reduce costs. For example, reduce emergency department visits. We can better engage with the community and the state to say, what are the needs of our patients and how can we bring or deliver better services to meet what their needs are? And really getting standardized data to see the big picture. So getting population health data from the PREPARE data set, but also the clinical data set, and then data at the community level. Next slide, please. So PREPARE stands for the Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. So the screening tool, the tool that asks the patients what their social determinants of health risks and barriers are, is only one part of the PREPARE initiative. The other big piece of the PREPARE initiative too is tools and resources on the implementation or the action of, once you find out what patients' needs are, what is the health center able to do to address those needs? Are the current services, those enabling services, those wraparound non-clinical services, are they adequate to address those barriers? If so, we have a total picture for what impacts patient outcomes, and we have the services for patients. And if not, what other services do we need to bring to the table or to connect the patient to in the larger community so that we could improve their health outcomes and address those social determinants of health barriers? So really two critical pieces to the PREPARE: assessing patients' needs and addressing their needs, addressing and finding ways to address those needs. So next slide, please. So this is just briefly the domains or the areas of patient social determinants of health risks and barriers that we ask about in the assessment portion of the tool. And as you can see, 9 of it is already currently collected in the UDS. So if health centers choose to implement PREPARE, it's really an additional 7 that they'll need to add to the workflow and to the project. Next slide, please. So really, again, 17 core questions, and when we designed it in mind with the engagement of really experts and health centers and patients to see how the tool would work, really how it can be used at the health center level to affect change, and then how the health center can use that to affect change at their community and state level. And then it can be used in combination with other tools or our data set. And really, it's meant to also help the health center bridge with their patients, connect with their patients more, and other social service providers within the community as well. And so next slide, please. We have crosswalked with a bunch of other national initiatives that is happening, so it's not a duplicate process for the health center. We know that health centers are already are having to collect a ton of data and reporting for other projects. So we didn't want it to be burdensome, but at the same time, have it align with other national projects too. Next slide, please. So the other part of which I talked about, the part of prepare that I mentioned earlier is once you get at what are some of the needs and the barriers, the other critical piece is some of the response that the health center is able to do, or the response that the health center needs to develop in order to address the needs identified. And really both sets of information incredibly valuable for the health center to have and really demonstrate what value the health center brings to the table when you're engaging in any kind of discussion with your partners at the community or at the state level. So next slide, please. And these are the categories or the domains of responses that we have captured in a standardized form for the health center to be able to really document, okay, so I have identified with this patient that transportation is the key barrier for them. So I'm going to go ahead, on the other hand, to document that I've provided a referral or a transportation service to this patient so that when I look later down the road, I see that a need was identified and something was done at the health center level and time was spent by health center staff to address this non-clinical need by the patient. Next slide, please. So I wanted to share some of the lessons that we've learned so far from the implementation of the Prepare screening tool. And then we'll make sure to send additional resources because we have a ton of them from the lessons that we've learned, but I've just shortened it for the purposes of this presentation. So next slide, please. So there are templates for 4 common EHRs available for folks to go and download and import for use in their health center, on NextGen, on eClinicalWorks, on GE Centricity, and on Epic. And these were made available by our pilot testing team. Next slide, please. So what we found through the pilot, and as we're expanding the work, and as more time passes with our pilot sites, we're learning that in some cases, it's easy to administer the tool. It's possible to implement using different types of workflows with different staffing models. It really builds this patient-provider relationship. So the providers have told us that, yes, we have known that our patients face these multiple barriers before they walk in through the clinic door, but now this gives us a way and a mean to talk about what those needs are and to present that to the larger health center and to the community about what these needs are. It really helped the health center identify a growing area of need from a specific patient population. It has been leading to positive changes at the patient, to the health center, and the community level so far. And it really facilitates further collaboration at the health center level with other social service providers in the next slide, please. Okay. So I see that we're just a little bit stuck. I'll start and then before on to the next slide. Some of Some of the most common risks we saw were high stress and a high school education, uninsured, unemployed, and a preference for language other than English. We were very surprised to see that generally patients were socially integrated, and that half of patients see people they care about 5 plus times a week. But again, this varied by the community. So when we broke it down by the community level, it varied. But generally speaking, that was what we saw. Next slide, please. So this is just a tally slide, which is about patients experiencing multiple social determinants health risk factors all at once. So it's about 4 to 7, not including low income, because we know that health center patients are typically underserved and low income. So what we really saw was 4 to 7. Could you imagine having this kind of data when you're sitting at the table talking about payment reform and talking about what it really needs to improve patient health outcomes and what it really requires to address 7 social determinants of health risk? This changes the conversation that altogether, and it really helps the health center highlight what are the needs of their patients and how complex it can be to really improve health outcomes for some of these patients with so many risks. So next slide, please. And then we just did basically a brief correlation analysis between the number of social determinants of risk factors and hypertension. So what you're seeing is a trend, the trend line, the red line is the trend line. So as the number of social determinants of health risk increases, the likelihood of having hypertension increases as well. The population of focus remains small. So we looked at the R value, which is the correlation value, and it's 0.061, which indicates a moderately strong linear relationship. So that really just means that as the number of risk increases, the likelihood of having hypertension increases as well. But there's really a lot more work to be done. And as we're continuing to expand the prepare work, we're going to be able to do much more powerful analysis rather than having the smaller number of the patient of focus for now. So really, next slide, please. We were able to see some changes in terms of driving policy at the state level for the sites who were participating in the project. So for example, one health center was able to use the prepare data to make the case with insurers to advocate for support for intervention services, because they clearly didn't have some of these services in place to address these risks. So for example, they indicated a need for job training because of the high population of unemployed health center patients. For homeless patients, they were able to demonstrate the need for housing services, and then also to connect with aid services organizations as well. Another health center was able to use the prepare data to present payers, to present them with conflicting information about their patients. Prepared data also helped the health center provide analysis to predict who is at risk of becoming higher risk patients and prevent them from becoming too high risk or to are high utilizers of the emergency room. There are further examples of health centers using the prepare data for advocacy in discussions with the Medicaid director about the need to acknowledge the importance of the social determinants of health that affect patients on the state level, and emphasize what the health center program has been doing to address some of those risks and how they can result in better savings. So we really have a ton of examples so far from our pilot work about how they have been able to approach the community, but also the state level with concrete data on what the barriers are and how to address them. And I think really that's the key, as Kersten and Isha has mentioned, is really having this data on your patient center is doing, so that you can ensure adequate is made available to the health center to fully address social risk and all those services that currently providing need to provide to ultimately improve patient health outcomes and drive systemic change. So with that, I will end because I'm running over time, and I will have, I think if you skip to the last slide, Isha, there's resources available for folks to check out, but also we'll make sure to send them the links and anything else after the call.
Thank you so much, Tuyen. So that was really helpful to hear about the Prepare project. And yes, both of you have been talking about a lot of resources, and we did get a question about this PowerPoint, the PowerPoints and the recording and the resources. And we will be sending a link with the slides and the recording and key resources after this webinar. So thanks for that question. We're going to go into the Q&A section with a couple of minutes left. As you may have seen in the chat, if you have any questions, please put them in the questions tab in your control panel, and I can direct those questions to the appropriate speaker. And while you're putting those questions in, I have a couple of questions, and I'm going to direct my first two questions to Kersten. So my first question is, what can health centers do to affect 1115 waivers, even if a state doesn't have one in place?
Great, thanks so much, Isha. That's a good question. So I think it's, first and foremost, I think is staying plugged in. States don't have an 1115. They might be looking to pursue one, and in the coming years, that waiver could be shaping eligibility for your patients, the services that are provided within the Medicaid program to your patients, as well as the services and payment for health centers, as well as different array of things within the Medicaid program. And so I think a couple key things that folks can do, when you're staying plugged in and if a waiver does occur, being able to learn what's in that and how do you really engage with the process that a waiver has to go through. So it's important to first, I think, education, engaging people early already, to prevent a waiver that could be have negative impacts on policymakers, so your state legislator, your Medicaid director, your governor, about some different things that you're really concerned about or that you have found really great success within. And so having that open line of communication And I think particularly to FQHC services and payment, I think there's a lot of misnomers, misunderstandings about health center payment out there by other providers or policymakers. Might be very passionate about health centers, but they don't understand sometimes how health centers are supported to do the work that they do.
Sure.
And so being able to really engage and educate so that you can be building those relationships is important. And I think building up your own knowledge, understanding, what is an 1115 waiver? What's the process that a state's required to go through when they're considering waivers of certain federal statutes within the Medicaid program? Some of the different opportunities to engage and comment on those waiver proposals. So really, I think educating other than educating ourselves.
That's great. Thank you so much, Kersten. That actually answers, I think, my second question, which was, what would you say would be the key items for a health center to advocate to their state? So
yeah. I think it's totally, again, engaging with your legislators, your Medicaid director, your governor, and your state primary care association is a great partner. And they're meeting with these folks on a regular basis. And so being able to have a legislator that, represents you, come and tour your health center, just like we do with a lot of times congressional members, is really important. So they can really understand what the model looks like and what their constituents, how they're being delivered these services. So I think education and connection.
Thank you so much, Kersten. So I have two questions for Tuyen as well. So Tuyen, my first question is, you spoke a lot about that there are a lot of resources with Prepare and how it's been used. So my question for you is, for the participants on the line, what key documents would you recommend for them to look at first?
So I would recommend to go to the Prepare website, which has the implementation toolkit and it's resource with case studies of how the data has been used by the developer to implement the Prepare screening tool at the health center and the steps for documenting interventions. So that would be a really great and comprehensive resource for everyone on the call to go have a look.
Great. Thank you, Tuyen. And then my second question is, how can other health centers that are not part of Prepare get involved in similar efforts like Prepare? Or how can other health centers get involved in Prepare?
So as you're looking, aside from the resources that we have available online, we're going to be engaging second thing of the Prepare work, which is really working, as Kersten has noted, about the importance of engaging and connecting with your primary care association. We'll be providing support to primary care associations in a train-the-trainer approach to help them support their health center at the state level to not only implement Prepare, but also what to do with that data set once you have it and how to use that in meaningful ways to talk to the community and talk to the state. So in this next phase, which is coming soon, we'll be working with the PCAs. Definitely at the health center, you should connect, like Kersten had said, with your PCAs because they are great resources, and we'll be providing them with even more tools and resources that you implement and use and take Prepare to affect change.
Great, thank you, Tuyen. Questions. So we're going to wrap up. If you have any additional questions after the webinar, if something comes up, please don't hesitate to contact us at policy@apcho.org. We're happy to answer your questions on our website at www.apcho.org, and then Tuyen had mentioned the Prepare website, and also Kersten had also mentioned a number of resources that you can find through the NAC website as well. We are going to be sending resources, as we mentioned, after the webinar, along with the recording of the webinar. But I just wanted to take this moderator privilege and to thank Kersten and Tuyen for joining us today. It's been a real pleasure to have you present. And thank you all for participating today. Please keep a lookout for an email from AAPCHO, as well as some action steps as well. Thank you all again, and have a great day.
Great, thanks.
Bye.